Well, on now to our big focus this evening, the type of trials that we are doing to detect COVID-19 in India. Now, there are two main types, rapid antigen tests and RT-PCR tests, widely considered the gold standard in testing. RT-PCR tests are considered the gold standard. Now, consider the data, first all India and then in Delhi. And the question we are asking is India relying on accurate COVID testing data? Now, let's firstly look at this and let me explain what you are looking at. The time period 27 days from the 19th of June to the 15th of July. RT-PCR tests, that is the gold standard. 58 lakh tests done, samples taken. Rapid antigen tests, let's bring that number up full screen if we can. 3,60,748 total rapid antigen tests which have been done on an all India basis. So what do these tests show? Positive results in RT-PCR tests at 5,41,000 plus. Positive results in rapid antigen tests, in other words, those who have contracted the COVID virus, 27,421. But obviously, the number of samples much lower in rapid antigen tests, because at the national level, the number of tests using rapid antigen testing is lower. But here's the key point. The sample positivity rate in the rapid antigen tests, it's at 7.6. So, by and large, there is a certain commonality that you can see over there. But let's now change this and give you an idea of what the situation in Delhi is. In Delhi, it's 2,81,555 total samples using the rapid antigen tests, which account in Delhi of 70% of all tests. 30% of all tests use the RT-PCR testing model. The positive results in the rapid antigen tests are 19,418. In the RT-PCR tests are 44,397. And therefore, if you get the sample positivity rate, and this is a matter of concern, for the RT-PCR tests, it's at a whopping 36.84% compared in Delhi with just 6.92% of the rapid antigen tests. So, what are these numbers actually trying to say? We'll be looking at this and many other aspects on this program. We are joined by the director of the All India Institute of Medical Sciences, Dr. Guleria. Dr. Guleria, irrespective of the merits of the test, should Delhi be relying more on RT-PCR tests than the rapid antigen test?
So in my mind, we need to rely on both of these tests because we need to understand the pros and cons of each of the tests. The gold standard, like you said, is the RT-PCR test, which can be done in a lab or also done by now what is known as the GeneXpert or the TrueNat, which is a test which is also using the RT-PCR, but is using a machine which is usually tests for tuberculosis and drug-resistant tuberculosis.
Yep.
But that turnover of that machine is slow because the number of samples it can do at a given point in time is low. Now, the rapid antigen test, and this was validated when it first came at AIIMS itself before it was rolled out. We looked at it in our OPD area where we had our staff coming and other people coming. And what we found was that it is a highly sensitive test. That is, if you are positive by the rapid antigen test, you are definitely infected with COVID-19. But this test, it's a simple test. It gives you a result in 15 minutes. It's a point of care test. You can do it right there. You don't have to go to a lab. But the disadvantage is that if your viral load is low, then this test does not multiply the virus as the RT-PCR does. So if your viral load is low, then since it doesn't multiply the virus as the other test does, you may have a false negative test. Therefore, what we found was that in all those individuals who were symptomatic, who had classical features to suggest that they could have COVID-19 infection, the positivity was close to 70 to 80%. However, 30% or so were those who were turned out to be negative by this test, but were positive by RT-PCR.
Sure.
So what it basically means is that your first line, in case you need to really screen people quickly in the community who have fever and COVID-like symptoms, should be the rapid antigen test, because you can isolate them quickly. And one of the things that was happening was that it was taking a long time to get the RT-PCR result, and if you get it after even 3-4 days, that means that individual is actually spreading the infection for 3-4 days,
Sure.
and therefore you're losing precious time.
But Dr. Guleria,
But
is there not therefore a serious concern that given the high rates of false negatives which actually emerge from rapid antigen tests, particularly in asymptomatic patients, there is a worry that these individuals who actually have COVID have not been given the RT-PCR test, they are out there in the open, they have very mild elements of the illness themselves, but because they're potentially spreading it, somebody else with, say, comorbidities can pick it up, can suffer much more.
correct. So I would say that if you look at the guidelines, and the guidelines are very clear that if you have a negative RT-PCR, your rapid antigen test, and there is a strong suspicion that you may have COVID-19 because of your symptoms, or you are a close contact, then you should get the RT-PCR test done if you are negative. Because a negative rapid antigen test does not rule out active disease. The advantages are two of the rapid antigen kit. One is that it gives you a result immediately, and even if you have some positivities, it decreases the load on the lab which does the RT-PCR, and therefore you could do a larger number of tests in the lab as per RT-PCR. But it's very important that people who are doing the test at the ground understand the utility of this test and don't misuse it, because if you start doing it if you say that if you are negative by rapid antigen test and you are symptomatic, you don't have COVID-19, that is a wrong interpretation of the test, and thereby you are right that then you could lead to spread of the infection, development of clusters, and also infect the high-risk population, causing serious illness.
But Doctor, just one more question on Delhi. Given the discrepancy in the numbers that we are seeing in the positivity rate, these are ICMR numbers, between what we are seeing in Delhi in RT-PCR and rapid antigen tests, there's a huge discrepancy between the two. Could that be because of the standard of the kit in Delhi as far as rapid antigen tests are concerned? Because that's also a factor. Where have the kits come from? Earlier on, several months back, we spoke about kits procured from China. They were spread out, they did not work, and they were discredited. Now we have this discrepancy in Delhi at a time when the government is saying that, look, maybe we are doing well in the fight against COVID. So how do we account for this discrepancy?
So as far as the kit is concerned, there's currently one company which is supplying it. There are others which are also going for it. And all batches are actually now validated by ICMR because of the previous experience with the antibody kit. Also, these are kits which come from South Korea, and now they are being manufactured in India only. And there is a plant which is approved by the DCGI, which is in Manesar, and therefore now they are made in India by the company which is a South Korean company, and therefore there is a lot of quality check which is done because of past experience. So I'm quite sure that the kits are of good value. The only issue is that people who are doing the test have to be trained properly, first how to do it in terms of taking a proper nasal swab, and secondly that you have to be able to understand the limitations of the test. And like I said in the beginning, that if your test is negative, it does not rule out COVID-19 infection. And if you have a high index of suspicion, you must get an RT-PCR test done.
Right. All right. And Doctor, tomorrow is an important day. Tomorrow is when we actually begin human trials of the vaccine being developed in India. Tell us a little bit about that, because you've been part of the process which has said that, okay, fine, go ahead with the testing. How extensive will this testing be?
So we are now starting phase 1 of the trial for the vaccine. These are human trials. So what was done in the past few days was the data was looked at extensively as far as the animal data was concerned to make sure that the vaccine is safe. The first concern is that when you're giving it to humans and you're giving it to healthy volunteers, you must have a good backup data to show that the trials in animals showed good safety profile. That was looked at by the ethics committee, and they satisfied themselves, all the members satisfied themselves that whatever animal data is there suggests that the vaccine is safe. And now we can move to the next phase, that is the human trials. And the first phase will be to actually give it to a group of healthy volunteers to make sure that there are no side effects or no signals to suggest any side effects of the vaccine that we're giving.
Right.
And then we will move to looking at the efficacy, that the vaccine produces good immunogenicity and the immune response is good. And then the next phase is to see how it behaves in a real life situation and how effective it is in the elderly, in children, and in high risk groups like people who have comorbidities in terms of protecting them.
All right. Thanks, Doctor, very much for sharing those details with us. Now, we did reach out to the ICMR on COVID testing, and I think it's important that we read out what the ICMR has to say about the two different types of testing. They say symptomatic individuals who test negative for COVID-19 by the rapid antigen test should be definitely tested sequentially by RT-PCR to rule out an infection, whereas a positive test should be considered as a true positive and does not need confirmation by the RT-PCR test. Well, let's focus a little bit more on this. I'm joined now by Atishi, the MLA of the Aam Aadmi Party and spokesperson as well. Besides anything else, Atishi is somebody who's better now. She's recovered from COVID, and that's a relief to all of us who who look upon her as somebody who's really been inspirational in so many areas. But Atishi, why don't you tell us a little bit about this discrepancy in numbers that we are seeing as far as testing is concerned? Now, there is enormous data around the world which suggests that RT-PCR is the gold standard. I understand that you need to do quick tests in Delhi, which is why you're using the rapid antigen tests. But the fact is the number of low positive cases in rapid antigen tests, is that not a worry for you?
So Vishnu, I think two things we need to understand when we are looking at rapid antigen. So when we do RT-PCR test, if you see that there is a limited bandwidth that labs have, and RT-PCR is a complicated test process. It involves extraction of the RNA from the swabs that are taken from the patient, and then after that RNA is extracted, it is processed and then it's tested. There will always be a limit to the number of RT-PCR tests. So what was basically happening? That with just the test capacity of RT-PCR tests, we were only able to test those people who were developing COVID-like symptoms, and they were referred by doctors, be they government doctors, be they private doctors. They were getting referred for RT-PCR tests. But the fact is, we also know about this disease that there are a lot of asymptomatic carriers. And to do any large-scale testing on the field, in containment zones, in what we know are high-risk areas, etc., it is not possible to do such large-scale testing by just focusing on the RT-PCR. With the RT-PCR, we can only stay within the range of maybe about 3,000 to 5,000 tests per day. And with the antigen testing, the amount of testing can actually go up to 20,000 to 25,000 samples per day.
And now with the question that arises, I understand that the limitations that you're talking about. However, is there not a real worry that if you are using a test which is unreliable in the large number of cases, particularly on people who have the most minuscule symptoms, which could be anything at all, not necessarily COVID, they turn out to be negative when in fact they are positive, they are out there in the open believing that they're absolutely fine, they enter workplaces, they enter shopping centers or whatever it is, your neighborhood market, and they end up infecting people who are vulnerable, right? I mean, is that not a real worry?
So I think we need to understand two things, Vishnu. First of all, anyone who is symptomatic, even if their symptoms are mild, and they test negative in the antigen test, are sent for an RT-PCR test. So anyone who is symptomatic, yes, they are sent for a further testing. And in Delhi, that number is actually, interestingly, we found is not more than 5 to 7% who are symptomatic and have to be referred to RT-PCR. So that's number one. That's an encouraging number.
Okay.
Number one. Second, I think what we need to understand is that as far as Delhi is concerned, the data about lowering number of cases is corroborated by two other data points. One is the number of hospital beds that are currently occupied, as well as the number of deaths that are happening. So even if we assume that for whatever reason, our testing data may be showing up wrong data, and we are seeing that trend, we are not capturing an accurate trend of the reducing number of cases. But if a patient is sick, even if they are suspected COVID patients and they have not yet had a test, any kind of patient who gets a severe symptom lands up at the hospital, whether they are tested or whether they are not tested. But we can see the fact that from about 24th June onwards, hospital occupancy has been steadily decreasing. And now
that's
Delhi
an important
stands,
point.
Yeah,
That's an important point, because I think the argument over there is, if you are genuinely, or not genuinely, if you are extremely unwell, you have to go to a hospital, right? Irrespective of the test that you've gone through. And so what you're saying is that the footfall in hospitals of COVID cases has gone down, and therefore that is a direct indicator of the infection being at a lower number than earlier. But Atishi, I think the question that everybody wants...
It's actually not just the hospital beds, even the number of deaths that are happening with anyone with COVID-like symptoms. You must realize that when we count the number of deaths, it is not just those who have been tested positive. Those who are suspects also do get counted in the death data that is coming in every day.
Okay.
And
Atishi, I need to interrupt you because I need to move on, but I have to ask you one basic question. Do you sincerely believe that Delhi has almost flattened the curve? Do you believe we are on that path now? I mean, because we've seen what the Chief Minister has said. There is this data which is, it's sort of all over the place. People want news which is accurate. What is the accurate story here?
See, I think Delhi has definitely plateaued in terms of the number of cases. The number of cases coming in every day are lower than they were. The number of deaths is lower. The amount of hospital occupancy is lower.
Okay.
The number of people in ICU beds and ventilators is lower. But I think that we should just not be complacent too soon. I think that all the core measures that need to be taken, be it wearing of masks, be it social distancing, be it all the precautions that we have to take, I think we cannot let go of those, because we have seen in many countries across the world that you have seen a second wave of infection. And we do not know enough about this disease to know how herd immunity will develop, what is the benchmark by which it would happen.
And of course, there's that entire controversy on herd immunity itself that we'll save for another time. Thank you very much, Atishi, for joining us. And